Good morning, everyone, and thank you for the introduction. Just to start off, I just sort of let you know where those of you that aren't familiar with New Zealand, this is Auckland, the city where I live and work. It's a city where it's probably about an hour's drive between the east coast and the west coast. Auckland City has a number of islands in the Cervical Gulf, which creates areas for recreation, fishing, etc. Beautiful white sandy beaches. One of our landmarks is our Sky Tower, and close by to Auckland is this beautiful island, Waiheke Island, which has beautiful white sandy beaches, recreational activities like kayaking, fishing, snorkeling. You can collect shellfish such as scallops and mussels off the rock, and also it's very well known for its beautiful wines. So today I'm going to give you an overview of cervical screening in New Zealand, the New Zealand National Cervical Screening Program and the Operation Policy Standards, liquid-based cytology in my laboratory in Auckland, and our experience with the trial of the imaging system and the introduction of that system and the benefits that we've seen. So cervical screening in New Zealand, we have a population of 4.4 million, and with 450,000 cervical smears screened annually. There's a 3-yearly screening commencing at the age of 20 years, and the 3-yearly screening was chosen because with regular screening we felt that women would be protected from developing cervical cancer, but also minimising the number of visits they'd have to have in a lifetime. And of course, the screening ceases at the age of 70. Now, in our cervical screening guidelines in New Zealand, a patient that is outside those guidelines, if we receive a smear from a 19-year-old or a 71-year-old in the absence of clinical symptoms, of course, we must report a small comment back to the smear taker to say that this patient's outside the guidelines. 200 women are diagnosed annually with cervical cancer, and of that, 70 will die. The incidence is 7 per 100,000, and this has decreased since the introduction of our screening program in 1990 by about 40%. Cervical cancer rate in our Māori population and Pacific Island population is, of course, higher. And in the Māori population, it's about 40% higher than New Zealand European women. Of course, we've had a couple of high-profile adverse screening events, but I'll just refer to one of them, and it's the Gisborne inquiry in 1999, and this is where the Health Funding Authority investigated an allegation that there was under-reporting in the Gisborne region. This became a complex task where 23,000 smears had to be reviewed, which impacted on 12,000 women in the Gisborne area between 1991 and 1996. Of course, the results of that screening, of that inquiry, did show that there was a significant under-reporting of cervical smears, and this was because a pathologist in the area was working in isolation. Diagnostic Medlab is a very large laboratory, and the cytology department is the largest lab in the country. In 1997, our laboratory decided to introduce the ThinPrep liquid-based cytology, and really we did introduce liquid-based cytology into New Zealand. And I guess for the volumes of samples we process, you could argue that we're the largest users of ThinPrep in the Asia-Pacific region. With the introduction of a new system, we also had to introduce new technology, and we started off with one 10,000 processor, which is a semi-automated processor for processing the cervical samples. The technology grew very quickly, despite the fact that at this time patients did have to pay for the thin prep vial on top of their normal consultation fee, and patients would pay anything between $15 and $25 for the vial. Didn't seem to put them off though. By 2003, we were receiving between 40,000 and 50,000 liquid-based samples. My laboratory processes 130,000 cervical smears per year. By 2006, 2007, we were processing about 70,000 thin preps, and of course we grew the technology to process. We ended up putting in about 3 T2000s. In New Zealand, we have to tender for a cervical contract, and we have 7 laboratories in New Zealand, 5 in the North Island, 2 in the South Island. 2 of those are hospital laboratories, and the other 5 private laboratories. So in 2009, the next round for our cervical screening contract, we were directed to go to 100% liquid-based cytology for the entire country. So what this meant for diagnostic, or my laboratory, was we had to also look at the technology that we had and replace our T2000s with the T5000s. And we'll look at that in 1 minute. My laboratory prior to December last year had 25 scientists and technicians. We are now down to 15, and that is because we introduced the thin prep imaging system, and for this to be cost effective, the increase in the cost of the imaging system, for this to be cost effective, this was held against the cost of labour. So we actually made 10 of our scientists redundant. We have 13 histopathologists, 6 of which screen gynae cytology, and we're very fortunate that the scientists and technicians in the department don't have to do any preparation. We've got a team of preparation staff. So just to reiterate, the cost of the equipment in the thin prep imaging was offset by the savings in labour costs. As I said, the National Cervical Screening Program was developed in 1990, and we've certainly seen a decrease in the incidence of cervical cancer since the introduction of the program by about 40%. In the year 2000, the operational policy and quality standards were introduced for laboratories as well as smear takers and colposcopists. And these policies, the purpose of these policies and standards was to document the policies and standards for users or providers of the service. And this was really initiated from the outcome of the Gisborne inquiry. For a cytology department to have a tender, they had to have a minimum volume of smears processed per year, and this is 15,000. Cytotechnologists and pathologists must be involved in continuing education, both externally and internally. We have maximum workloads for screeners, and annually screeners must screen at least 3,000 samples, and my screeners would probably do that in 6 months. We did have a re-screening policy where all normal cervical smears were rapid re-screened prior to reporting, and this with the introduction of the thin prep imaging system, this process has now been made redundant. The automated screening device, of course, operational policies and standards had to be introduced around this technology. We still have a full rescreen of smears. This is targeted screening for women that are presenting with abnormal bleeding or clinical symptoms, or if they've had a previous abnormal in the last 2 years, they still get a full rescreen. The turnaround time for laboratories, 90% of smear results must be reported back to the smear taker within 7 working days or 7 days, and 100% must be completed within 15 days. Laboratories should also be involved in multidisciplinary meetings, and these meetings are a list of patients generated by the gynecologists to the laboratory, and this is usually where there's been a discordance in cytology or histology results or even colposcopy findings. Diagnostic Medlab are involved in 2 of these meetings each month, and we review the cytology as well as the cervical biopsy, take these samples to the meeting and meet with the gynecologist to discuss the future management and best management for the patients moving forward. Further developments with the National Cervical Screening Program was we do have a national register, and each laboratory is complied to report a cervical smear with the presence of the patient's previous cervical screening history. We should not report smears without this. We also introduced the Bethesda reporting system in New Zealand in July 2006, and it was a New Zealand modified Bethesda system, but really it offered standardised reporting throughout New Zealand. As I've already mentioned, National Cervical Screening Contract in July 2009 meant that all laboratories in New Zealand had to move to 100% liquid-based cytology. As well, in the same contract, we were also directed to introduce HPV testing by the 1st of October 2009. And since, we've also got policies and standards around automated screening device. HPV vaccine in New Zealand, this commenced in 2008, and we're using the Gardasil. It's been given to 12-year-olds, but there is a catch-up program to the age of 18. There is a national register, immunisation register, and this enables authorised health professionals to access immunisation history for all children, including HPV. And there's been very few adverse effects. The thin prep processing system, well, virtually all the sample is collected into the vial. It's randomised, representative transfer of cells, there's even distribution of cells in the preparations, and it really does minimise some of the limiting factors that we see with the conventional smear. Of course, the collection of the sample is the same as the conventional smear, except you must use plastic devices. In our laboratory, we use the T5000 for processing. This process is a fully automated system. It processes 20 samples at a time. The technology is very reliable and also has a chain of custody verification, so it doesn't allow for mix-up of samples in the processing. And Diagnostic Medlab was, I think, the first laboratory in Australasia to use this function on the T5000. A cell sample is made and put onto the thin prep imaging slide. which has special markings on it for the imagoscopes. The thin prep processor consists of loading a cassette of 30 slides into the processor, and these are scanned and 22 fields of view are identified for the cytotechnologist to view on the review scopes. Just quickly, this is the workflow, and so on identification of a normal, this can be signed out, whereas anything that needs review must have a full review and sent through to the cytopathologist. So our trial of the imaging system, it's computer assisted, and with our screeners' experience, we decided to stay with using the thin prep samples. We've got a 10 years experience, an average experience of screening history with in our Department of Cytotechnologists. And for our trial, it was a comparison of thin prep imaging assisted screening along with manual screening. Our aims and objectives were to investigate concordance of thin prep imaging assisted screening with manual screening, how it fits with the operational National Cervical Screening Program policies and standards, productivity gains and ergonomics. I won't go through this slide really because of time restraints, but our trial results indicated that thin prep imaging assisted screening was as good as manual screening for the detection of abnormalities. However, it was better for the detection of high-grade lesions. And any discordance between imager-assisted and manual screening is a result of screener variability interpretation rather than a failure of the imager to identify abnormal cells. We saw that unsatisfactory rates were almost halved, productivity gains were greater than 100%, and in New Zealand, screening program setting the initial screening by the imager removes the need for rapid review. These are our results. I've run out of time, I'm sorry, but I just want to say that with the thin prep imaging system and the review of these samples, it did indicate that where there was a high grade that was called a low grade on the thin prep imaging system, it was due to screener variability. Okay, I just did want to talk about HPV testing, but I have run out of time. I'm sorry. Thank you.
Thank you very much, Mrs. Singer, for the very informative talk.